Welcome to Team 3's presentation on not-for-resuscitation orders. What is a not-for-resuscitation order? A not-for-resuscitation order, or NFR, is a medical order that informs healthcare providers to withhold cardiopulmonary resuscitation if a person's heart and/or breathing stops. They are implemented to prevent the use of CPR in situations where it is deemed futile or unwanted. It is specific about CPR. It does not have instructions for other treatments, such as pain management, medication, or nutrition. Valid NFR orders are a legal binding document written up by a doctor in consultation with an individual and/or their families. They are a communication mechanism to ensure that the various members of a healthcare team on different shifts know what a person's wishes are. An NFR order forms part of an advanced care directive. NFRs are also known as do not resuscitate, not for attempted resuscitation, do not attempt resuscitation, allow natural death, no CPR. Historical background. In 1960, surgeons from Johns Hopkins Medical Center in America first introduced closed-chest cardiac massage as an effective way of resuscitating patients experiencing a cardiac arrest. This technique, which became to be known as cardiopulmonary resuscitation, CPR, soon became a routine emergency procedure for any hospitalized patient experiencing a cardiac arrest. In the mid-70s, concerns within the medical field arose that universal CPR was causing more harm than benefit for some patients. Articles in medical literature describe the agony that many terminally ill patients experienced from repeated resuscitation that only prolonged the dying process. In 1976, hospitals began to develop policies allowing patients to forgo CPR due to these concerns. These policies served to establish procedures for writing orders not to resuscitate. In 1983, the President's Commission for the Study of Ethical Problems in Medicine supported NFR order policies based on three value considerations. Self-determination. An NFR order should be based on a competent patient's preference. Well-being. CPR shall be withheld when this intervention will not benefit the patients. Equity. Resuscitation is part of care to which all patients shall have equitable access to. In 1991, the Patient Self-Determination Act was introduced. It required all healthcare institutions to inform patients about their right to complete an advance directive, including their right to refuse life-sustaining interventions such as CPR. How does this issue compare in Melbourne versus the rest of Australia or the world? Melbourne versus the rest of Australia. In Australia, all states utilise NFR orders. These orders form part of Advanced Care Plan, a Resuscitation Plan, or an Advanced Health Directive as follows. In Victoria, an Advanced Care Plan is used. It legally defines the medical treatment a person chooses to receive or not receive. In New South Wales, they use a Resuscitation Plan, which is a medically authorised order to withhold or use resuscitation measures. The remaining states utilise an Advanced Health Directive, which is a legal document that enables a person to make decisions now about the treatment they would not want to receive if they ever become sick or injured and were incapable of communicating their wishes. There is no standardised form Australian-wide, with each state and health service within the states using their own unique NFR form and accompanying policies. Australia versus the rest of the world. The definition of NFR orders does not change among countries of the world. It is the attitude to deal with it that changes. In several countries, the issue is faced in many ways depending on religious, cultural, historical, and ethical differences. Here are some examples. USA. Some medical organisations require patients and families to have a written NFR order, while others ask for a witnessed verbal NFR order. South Africa, oral NFR orders are preferred. UK, an advanced decision to refuse treatment is used after discussion with senior doctor and patients. Italy. Italy has established a national database for the registration of advanced treatment provisions. As of the 22nd of December 2017, the NFR was included into Italian law. This was to reaffirm the freedom of choice of the individual and make concrete the right to health protection. Taiwan. In accordance with local customs, most dying patients were taken home to die, but NFR orders are on the rise for patients who have been ill for a long period. Israel. Do not have NFR as a large part of their population has strong ethnic and religious beliefs. They believe in the peaceful transition from life to death. There is no worldwide universal term for not-for-resuscitation orders.
Not-for-resuscitation orders still remains a complex and ethical issue for debate worldwide. There are continuing debates about the ethics, legalities, and appropriate medical indications for the use of do not resuscitate orders. Some uncertainty still exists regarding the legal status of decisions to withhold and withdraw medical treatment in Australia, despite the fact that several states, including South Australia, Tasmania, and Victoria, have legalised the natural death legislation, which defines the competent adult's right to refuse life-prolonging treatment. It is a complex topic and can be viewed as a criminal act to the general public because of the lack of knowledge in the community. How does the issue affect the patient's families? For patients, it allows them to engage and be a part of their care plan. It can affect patients physically and emotionally when making the decision to either accept the progression of their terminal disease or proceed with a not-for-resuscitation order and die naturally. Some also have a feeling of anxiety and depression or the feeling of being a burden to others, including their family. For families, it is also an emotional and tough decision. There are positive and negatives with families being involved. Pros: allows them to also feel a part of their loved one's care plan for early discussion and education regarding the NFR order and medical issues. Presence may serve several functions, including reducing guilt or disappointment. Cons: own opinions and ethical beliefs and feeling pressured on choosing what they feel is best suited for their loved one's care. Family members feeling traumatized by witnessing this order and interfering with the medical care. How does the issue affect healthcare workers? This affects healthcare workers mentally, emotionally, especially for the healthcare workers who have already been a part of the patient's care journey and should seek support as needed for themselves, team members, patients, and families. They also have own beliefs and views on the not-for-resuscitation order. Given the seriousness of the consequences of an NFR order, increased pressure of perfecting extensive training and doing what's best for the patient and respecting their wishes, along with sometimes dealing with difficult family members who are against the order, question if it is the medically right decision. Doctors play an important role in the provision or withholding of resuscitation treatment in nearly all situations. Where a DNR order exists, doctors play a critical role in assessing its validity, and where a DNR order does not exist, doctors assess whether the patient has capacity to make such decisions, and if not, who is authorized to participate in the making of such decisions on the patient's behalf.
Does this issue require a nurse to make an individual choice or put the nurse in a situation where they may feel uncomfortable? As a nurse, you will be put in many situations where you may have to make an individual choice. For example, how you may provide care to patients depending on their medical circumstances. You may also be put in situations where you feel uncomfortable. For example, the patient may refuse treatment due to their religious beliefs. This could save his or her life. However, at the same time, this may make you feel helpless as you are unable to do anything in this situation. Regardless, this is the patient's choice, and as a nurse, it is your job to respect their wishes and put your feelings aside. I do not believe when a patient who was sound of mind at the time, who has chosen not to be resuscitated, requires the nurse to make an individual choice. The choice of the patient is out of our hands, and we have a legal requirement to follow the DNR. At the same time, I do believe this may take some stress off the nurse, as you already know what the patient wants when the time comes. However, in a circumstance where the family overrides the patient's DNR, this may make the nurse feel uncomfortable, as they would have known the wishes of the patient. Despite feeling uncomfortable, you must respect the choice of the family and start CPR. Making the call to the family saying that their loved one has passed away and dealing with the patient's family afterwards is another situation, also one of the hardest situations, where a nurse will feel uncomfortable, as some families may not understand why we did not commence CPR even with a DNR in place. Why you may choose not to have CPR. Patients who choose not to be resuscitated usually do so as they believe they will not have quality of life as they have or had before. Patients who have been resuscitated are unconscious and not breathing. This may lead to lack of blood flow to the brain, which causes abnormal cell activity when blood flow is restored. The risk increases the longer CPR is not performed. Survival rate after resuscitation for patients already in hospital is 6 to 15%. Survival rate for patients in a nursing home is 1 to 2%. People suffering with chronic illness such as cancer, dementia, or people who are on palliative care have a survival rate of 1 to 2%. What happens if you ignore a DNR? Failure to do so leaves the doctor and nurses vulnerable to a complaint, disciplinary action, or legal proceedings, and more importantly, they fail to respect the patient's wishes. By ignoring the patient's wishes, you may be making an impact on their quality of life.
Are the frameworks of ethical decision making for nurses relevant to this situation? Do the ethical standards provide guidance? Not for resuscitation are more family decisions in palliative long-term care. In cases of emergency, it will be the treating doctor, ED or ICU consultant who will make the call to cease resuscitation. Making good ethical decisions for NFR orders require thorough training and discussion to view different aspects of this order and weigh in the considerations that should impact the course of action. Nurses are to respect wishes of patients, families, and medical teams and continue to give the highest appropriate care to the patient. Nurses are encouraged to take an active role in developing do not resuscitate policies within the institutions where they work. In healthcare organisations, do not resuscitate policies should be in place and enable nurses to effectively participate in this crucial aspect of patients' care. As primary continuous healthcare professionals, nurses have a key role in the planning as well as the implementation of resuscitation decisions. Nurses recognise that the resuscitation refusal by the patient with a decision-making capacity should be given highest priority, even when these wishes conflict with those of the healthcare team and/or family. Nurses also advocate for a collaboration with the healthcare team when dealing with do not resuscitate related issues and decisions.
Thank you for listening. Hope you enjoyed our presentation.